A very good afternoon, everyone. So, we're meeting after quite a while now, and well, I am sure that you must be following your schedules well. You're all the one that we discussed in the previous classes. You're all going through your schedules. You're following it well, and you're on it with your full force. So, whatever. First of all, I would like, as I said, I always congratulate the ones who've got their aspired ranks in NEET PG. And whatever the result was, we have to write INI-CET, which is on 7th May, and we are preparing for it, just forgetting what the result was, right? So, as of now, an academy is giving you 25% off on all the subscriptions, which is valid till April 30th, right? So, that is valid till April 30th. So, you must go ahead and take advantage of this offer because it gives you free physical notes as well as access to the NEET PG Vitals. And then the ones who are preparing for FMG, for them, what we have is a 3 months subscription giving you 200 plus hours. And that would be really helpful for you to prepare ahead. And then the next, and for NEET PG aspirants, you can have a 9 months live subscription, right? We all will be together in that preparation, right? So you can use the code Bhumika for all the added benefits. And for today, the plan is basically the plan that we have. I have two classes on 25th. Good afternoon, Anilia. If everything is working well, please give me a thumbs up, give me a reassurance if there is no technical glitch. So basically for 25th and 26th, what I have is all this is the target is INI-CET. 25th and 26th, we meet on YouTube 3 to 4 p.m., which is 1 hour session where we discuss the topics. And then on 29th, I have planned a rapid fire PYQs, right? So we do a rapid fire PYQs, that is just to give the revision to PYQs so that we do not miss them, at least the ones which have been asked in the past, we do not miss on to them, right? And that is a free special class, right? That is a free special class which is on the platform. All right, so that is on 29th, and that is scheduled for 2:45 to 3:45 p.m. That's again a 1 hour session. So basically, all these three dates that I'm talking about, 25, 26, and 29, are for INI-CET preparations, right? So with all this, let's get started. So, all right, if everyone's there, okay. Now, what you have to do is tell me, identify this. And you all know that I don't like giving options because I want the preparation to be on a level that you don't need options. The ones who've been learning with me know it well. So, all I want is, what is this? All right, Chandani says Snellens. Snellen. So Shruti says Snellen and Dr. Sumit says Snellen's chart. Absolutely. Now you write it down in the chat box. Why is it Snellen's chart? You're absolutely right. What we are dealing with is Snellen's chart. How do you identify this chart? So basically, if you pay attention, what you have is you have one number here. This is one alphabet here, two here, three here, four here, two, three, four, five here. So if you see, if you follow one by one, the number of alphabets is increasing. So that is the way to identify. When we talk of Snellen's chart is basically when you have alphabets, but they are increasing as we go. So the number of alphabets is not maintained, right? So what is Snellen's chart? Snellen's chart is basically, when we talk of Snellen's chart, it is used for distance visual acuity testing, right? This is used for the testing of distance visual acuity. It is used at a distance of distance, right? Subtending an angle of 5 degrees. Absolutely. So basically, it is used at a distance of, what is the distance that we use? We use it at a distance of 6 meters or 20 feet. Okay. And the another important thing is that this alphabet, every alphabet subtends an angle of 5 arc minutes. Absolutely. So they subtend an angle of 5 arc minutes at the nodal point of the eye. So if you see this carefully, what you see is there are numbers 60, 36, 24. So what are these numbers? If I ask you, what are these numbers here? 60, 36, and 24, and all so and so. What are these numbers? You can see these numbers. Even here it goes 18, 12. So what are these numbers? These numbers are basically, they are the distance at which these alphabets subtend the angle of 5 arc minutes, right? So this alphabet, this A alphabet subtends an angle of 5 arc minutes at the nodal point at 60. This subtends an angle at 36. This extends an angle at 24. So this is basically the distance at which it subtends an angle of 5 arc minutes at the nodal point of the eye. And when we write the vision as 6 by 60, right? Or we write as 6 by 18. So what does that mean? What does the numerator mean? So numerator is basically the testing distance, right? And this is the numerator. And what is denominator? What is the denominator? Like 60 here and 18 here. What does denominator? Yes, it is when we say 60 or 18, the easier way is the smallest letter that the patient sees. You're absolutely right. The distance at which I told you 60, 36, 18 is actually the distance where it subtends an angle of 5 arc minutes, but that is how it is labeled. But when we write the reading of Snellen's, we write it 6 by 60. So that means the testing has been done at 6 meters, and the smallest letter that the person could read, the smallest letter that the patient sees, that he could or she could read, is that 60 or 18. Okay, so this is the Snellen's visual acuity. But what are the problems with this chart? So this chart had certain problems. So what are the issues with this chart? The issues that we have with this chart is that the reduction is non-uniform. By that I mean when we go from 6 by 60 to 6 by 36, or from 36 to 24, the change in the size, the reduction in the font size is non-uniform. That means the reduction from 6 by 60, if it is 25%, then from 36 to 24 would be, say, 20%. So this reduction is actually not uniform. And the second problem that they have is that the optotypes which are used, or the letters that are used, are actually said to be genetically difficult to learn. Like the alphabets like C, G, O, right? So these optotypes are said genetically difficult to learn. Hence, there are issues with the Snellen's type. So to meet these issues, what was introduced? To meet these issues, what was introduced was this. And what is this? What is this? Now you identify which chart is this. Anybody wants to attempt? Which chart is this? ETDRS. Or what is the other name for this? So basically, you're right. This chart was given by Early Treatment for Diabetic Retinopathy Study, or it is called as Logmar chart, or it is called as Logmar chart. So Logmar basically means logarithm of minimum angle of resolution. So this is the logmar chart. So now how will you identify this chart? So if you see carefully, 1, 2, 3, 4, 5. 5 letters in first row. 1, 2, 3, 4, 5. 5 letters in the second row. 1, 2, 3, 4, 5. 5 letters in the next row. Even the smallest have 5 letters. So how will you identify them? They have the same number of letters in each row, right? So this is in contrast to what we learned in Snellen's. Snellen's, you see, 1, 2, 3. So the number of letters is differing, but here the number of letters remain the same, right? So when this chart was made, this was made to read at the distance of 4 meter, but can be used at 5 meter also and 6 meter also, right? So initially it was made to be read at 4 meters, but now it can be used at 5 and 6 meters. The advantage for this is that it is a better chart. Hence, this is used for research purposes. Research purposes. It is more accurate. It is better. It is more accurate. So if you are given an option between ETDRS chart, Logmar chart and Snellen's chart, which of the two charts is used for research purposes, what would be your answer now? Is it Snellen's or is it Logmar? Tell me, what would be your answer? Which chart is used for research purposes? Which chart do we use for research purposes? It is ETDRS or the Logmar chart, right? So this, since it is more accurate, since it is better, hence this chart is used for absolutely Chandani, right? Then we come to another. There are these modified ETDRS charts with certain optotypes. Let's see. So you identify chart A first. Which chart is this? What is the name of this chart? A and B. Write it in the chart box. What is the name of the chart A? So now these are two charts, and the purpose of using these two charts was used in illiterate people, or the better term to use is pre-literate people. So what is the name of these charts? So tell me now. For uneducated, for illiterate people, for pre-literate people. So the charts are absolutely Shruti, which is tumbling E. So A is tumbling E. E chart. And which is B? B is Landolt C chart. So basically, what you have is these charts are easier to be recognized even by an illiterate person, even by a person who's not read, who can tell you where do these sides open. So for illiterate, for pre-literate people, which charts are used? We use tumbling E chart or Landolt C chart. So these two charts can be used in pre-literate people. Then, which is this chart? HOTV. O. If you see HOTVO, and then they are using the same optotypes. So which chart is this? Which chart is this? This is called as HOTV optotype chart. HOTV optotype chart. So these are said to be using which letters? Sloan letters. So what are these Sloan letters? Basically, by Sloan letters, they mean they are in a format which is easier to be recognized and the letters itself are not confusing. So this optotype was made called as HOTV type optotype, which are easier to recognize. They are not alphabetically similar to other alphabets, and these are called as Sloan letters. So what do we call them? We call them as Sloan letters, right? So HOTV optotype uses Sloan letters. And which is this chart? This is basically a picture chart. This is a picture chart, and it is the type of this chart is called as, it uses Leah optotypes, right? It uses Leah optotypes, and the picture charts are basically used for small children, right? They are used for small children. So now you get, so this is HOTV or the HOTV optotype, which uses Sloan letters. And here you can see it uses pictures. So pictures are more preferable for people who are like children who cannot recognize letters. Right? So when we talk of HOTV, I said you have to remember these are the Sloan letters. So how do people recognize? They just show you that this, which is this alphabet. They will have a sample reference to show you that this is the alphabet which is shown. So one, it is not confusing, and it is a simple format which is used for on the charts. Right? So do you get that? Can we go ahead? So these are the modified ETDRS charts and the Snellen's chart. So they are all used for testing distance visual acuity. All right, can we move ahead? Is everything okay? All right, so moving ahead. Now you have to tell me, what are you seeing on the screen in picture A and in picture B? So what is seen in A? Tell me. And an easier question, part 2 of this question is, where is it used? Where is it used? All right, Ishihara charts. That is right. Ishihara chart is seen in B. It is used to detect color blindness, Ishihara chart. So my first question, everybody has skipped to part B, answering the B option. What is A? I need to know what is A. So I asked you 3 questions. Last 2 have been answered. The first question itself has not been answered. In anybody wants to make an attempt? What is A? What is this? Okay, I will write and you also write. Edrich green lantern. This is the Edrich green lantern test which is used. And this is used to detect color blindness. You're right. To color defects or color blindness. I would rather call it to detect the color defects. So now we come to an important topic of color defects. So what are the yes, it is lantern chandani, good, but I would have been more happy if you would have given the entire name. It is Edrich green lantern test. So basically the patient tells us what the colors are seen through this lantern, and then we calculate what is the error that he gets. What are these? As you rightly said, these are the Ishihara charts. So I would better call it as pseudo isochromatic plates. So these are the pseudo isochromatic plates which are used for detecting the color defects. So what are the types of these plates? One type is Ishihara charts. The Ishihara charts which are shown here. So the Ishihara charts are the most commonly used charts to detect these color defects. And what are the other types of pseudo isochromatic plates? One I said is Ishihara charts. The other type is HRR plates. What are HRR plates? HRR plates, I mean Hardy, Rand, Rittler plates. And they are more sensitive as compared to Ishihara charts. So what you get is Ishihara charts have a number which is written on a colored background. But when we talk of HRR plates have, I will write it here, I think the sensitive has been hidden behind me. It is more sensitive. Right? So HRR plates have a gray background and then they have a number written in a color on that gray background. Right? So HRR plates are more sensitive as compared to Ishihara charts, right? So what happens is basically if you see these numbers, a normal person would read a different number, whereas a person who has a color defect would read a different number. So these are the two types of pseudo isochromatic plates. One is the Ishihara charts, that is one variety, and the other variety is the HRR plates. So these are the types of pseudo-isochromatic plates. Most commonly used is Ishihara, but more sensitive out of the two in the pseudo-isochromatic plates is the HRR plates. All right, coming to the next. Now, what is C and what is D? What is C and what is D? Now you tell me. What is C? Absolutely. I'm so happy, Dr. Sumit. You're absolutely right. It is a Farnsworth-Munsell 100 hue test. Now you have to tell me the option D. Anybody? This is Green's wool test. All right, this is right. Very good, Jitendra. So basically, when we talk of the Farnsworth-Munsell 100 hue test, this is the most sensitive test, or I say this is the best test to identify because it identify all the three types of color defects, right? So this is most sensitive. And another important thing to remember here is we call it as 100 hue, but it does not have 100 chips. It just has 85 chips. Right? So basically what you do is there are these chips which are present, which the patient matches with the color, right? So that is how we get to know. So it is the most sensitive test. So out of the two that we learned here, HR and Ishihara, the HRR is more better, is more sensitive out of the pseudo isochromatic plates. But the most sensitive out of all of these is the Farnsworth-Munsell 100 hue test. It is more sensitive, but remember it does not have 100 hues. It just have 85 chips. And this one is the Holmgren's wool test, right? And then to complete this, when we talk of color vision, what are the theories behind what are the theories behind the color vision? Color vision theory, what is the theory behind? What are the two theories of color vision? The two theories are, one is the trichromatic theory. One is the trichromatic theory, according to which there are three primary colors. And this theory is also called as Young-Helmholtz theory. Right? So it just says there are three primary colors, which is red, blue, and green. And all the rest are the mixture of these. And the other theory is the opponent theory. The opponent theory of Herring, which says there are certain colors which are perceived as mutual, certain colors which are perceived as exclusive. All right, so these are two theories of color vision that you must know. And quickly revising, this is the Edridge green lantern test. This is the pseudo isochromatic plates, which is more specifically called the Ishihara plates, which have a colored background and a number written on it. And if you have a gray background with the number, they are called as the HRR plates. So out of these two, HRR more common. And then you have this in this where there are chips which are present. This is called as Farnsworth Mansell 100 hue test. It is the most sensitive of all and uses 85 chips. I will write so that there's no confusion of all. And it uses 85 chips. And then there is the cotton wools, which is called as Holmgren's wool test. Right? Can we move ahead? All right. So then there are these three theories that we have already there are two theories which say there's three primary colors: red, green, and blue. All right. Coming to the next. The next question says safe strategy includes all except. This is easy, but then we'll quickly revise an important topic, which is trachoma. Now you all know this. Tell me. Absolutely. D. So it's a common answer. Yes. Safe strategy includes all except the answer you're right. The answer is D. It is not evaluation. So what is there in its part? It is absolutely. It is environmental sanitation. And what level of prevention is this? Which level of prevention is this? Write it down in the chat box till I come back to it. All right. Okay. So let's quickly revise. What are we dealing with? What are these pictures diagnostic of? These four pictures diagnosis is, tell me. And it is also called as Egyptian ophthalmia. What is that what we are talking about? We're talking of, so environmental sanitation, you say, is primary prevention. We'll come down to it. I will let you know. Which disease are we talking about? We're talking about trachoma. We're talking about trachoma. Trachoma is also called as Egyptian ophthalmia. Right? So let's see what are we getting in these pictures. Let's diagnose with the help of these pictures. All right. So I will label them and you have to tell me which are these. This is A, this is B, this is C, and this is D. Now quickly tell me, what do you see in A? A is good, smarty pants. Oh, you just people just have fancy names. This is nice. So it's right. It's a level of primordial prevention. We come back to it. All right. This is sago grains. Dr. Sumit, you are right. These are basically sago grains, or better called as follicles, and these appear like sago grains. Absolutely. What is point B showing? So what is this? Here is one and here is one. What is this? What I'm talking about is basically there is scarring. There is tarsal conjunctival scarring. And the one in white, specifically here, this is Art's line, which is scarring at the level of sulcus subtarsalis. Very good. What is C? What is C? So if you see carefully, if I zoom and show you what is C, you can see something here and see something here. So there's an infiltration and there is vascularity. So this is, what is it? This is fibrovascular penis, which is more prominent in the superior one-third. It is more prominent in the superior one-third. And last one is right, what you have correctly said. It is not cicatrization. These are the fibrovascular penis. So these, what you have is limbal follicles. You have is limbal follicles. I just put it with this. These are limbal follicles, or which is classically called as Herbert pits. So to say trachoma, how many out of these four should be positive or should be present? Tell me, out of these four, how many should be present to label it as trachoma? And don't forget, this is the follicles which are shown on the palpebral conjunctiva. Follicles on the bulbar conjunctiva are pathognomic of trachoma. Don't forget this. So follicles on bulbar conjunctiva are pathognomic of trachoma, right? So I have still not got answer. Okay, I have three. No, the answer is for clinical diagnosis. It requires at least two should be present. So two out of these four signs if present is labeled as trachoma, right? So is labeled as trachoma. So two out of these four is labeled as trachoma. And quickly revising the WHO classification or the WHO grading that comes, the WHO grading is famously called as Fisto. And which is the other grading which is present, which is available for trachoma? Anybody wants to attempt? Which is the other grading which is present? The other grading is called as McCallan's grading. Okay. So basically, what is Fisto? By F, we mean follicular inflammation, 5 or more follicles. I is diffuse conjunctival inflammation, scarring, trichiasis, and opacification, colon opacification. So basically, here is when we start getting into the complications of this disease. So basically, when we come to safe strategy was given by WHO under the program GET 2020. So what was this GET 2020? Right. So GET 2020 was global elimination of trachoma by 2020. So under this, it gave us this safe strategy, which is the other way around, which we read. E is environmental sanitation. And as I asked you, what level of prevention? It's not primary. This is what I was talking about. It's primordial prevention. It's primordial prevention. So environmental sanitation, that means giving safe water, clean water, refusal, waste disposal in a correct manner, keeping the hygiene levels. So that is what was targeted. It was a primordial prevention. Then you have facial hygiene, which is primary prevention. So facial hygiene, you should have a frequent face wash and avoid the common use of towels, kajals, all those things. Then you have antibiotic use, which is secondary prevention. So under antibiotic use, which is the drug of choice for trachoma? Which is the drug of choice? Come on, tell me, what is the drug of choice? Zainab, I'm sorry, this is the thickest that the iPad gives you. So this is the best that I can have. Yes. So antibiotic is azithromycin. Perfect. The drug of choice is azithromycin. And the surgery is the tertiary prevention. Surgery is normally done for trichiasis, for entropion. And what was the surgery which was recommended by WHO? Azithromycin, perfect. So what is the surgery that was recommended by WHO? Tell me. The surgery that was recommended by WHO is, you also write and I will also write. It is bilamellar tarsal rotation. Bilamellar tarsal rotation, which was recommended for trichiasis. The surgery was recommended for trichiasis and entropion. And under this, it recommended bilamellar tarsal rotation. Right? So this is all about trachoma. Absolutely. So it is bilamellar tarsal rotation, which was recommended. Okay. So now we move on to the next one. Okay. So what you have is, and I always say, whenever you read a question, mark it right there and then so that it saves on time. 42-year-old female reports to the OPD with complaints of retroorbital pain and diminution of vision. Fundus shows exudative RD with choroidal folds and an ultrasound image shown here. What does the image suggest about the probable disease? So basically, in short, it is asking you about the diagnosis. Come on, tell me the answer. Tell me the answer. So this is what you can see in the image. This is an ultrasound image, and what you are seeing here is there is a, what is this shown here? Okay, I'll mark two things that are important to be seen just for your, that is a hint, this and this. Absolutely, it is posterior scleritis. So you have to tell me what is A and what is B. What is A and what is B? This on the web. Okay, exudative detachment. All right, but that is not what I'm looking for. Zainab, I'm sorry. This is the thickest that I have right now here. I cannot increase thickness more than this. I'm so sorry. All right. So what I mean to show you is what somebody just writes at Chandani. You said exudative RD. So what we get to see here is this is exudative RD, right? That is one. But what I mean to ask you is this. Here, what you have, point A, what I mean to show you is a thickened sclera. A thickened sclera. And number two, that a B I'm showing is this is the optic nerve and this is the fluid in the posterior episcleral space. And which sign is this? Absolutely saint or sinner. It is absolutely Shruti. It is T sign. So what we're learning is, see, making a diagnosis is not difficult. I always tell you, just pick out the main things that I want to teach you. I want to tell you, because the image might be different. The person will not come and ask me, tell me which image have you taught. We will use the same image in the exam, but I'm teaching the major signs. So when we talk of these signs, what is A? A is the thickened sclera that we get to see in the ultrasound image. But if I talk in OCT, what we will have is we will have a thickened choroid. Okay, so if you do the OCT of this patient, you will have a thickened choroid. And what is B? B is the T sign. And why do we get a T sign? T sign is formed basically by this is the optic nerve which is present, and this that you get, the horizontal limb here, the horizontal limb of T. What is this? What is this? This is basically a fluid, or what you say, edema in the posterior episcleral space. Right? So answer here is very clear. It is posterior scleritis. Right? So two important things whenever we talk of posterior scleritis that you need to remember is thickened sclera, and on OCT a thickened choroid, and there has to be, basically when you see in the ultrasound, you are not able to differentiate the choroid and the sclera so much clearly. So what you get is you basically get a thickened sclera, right? And it's a basically sclera choroid complex. And if you see the OCT will give you a thickened choroid. And very important sign, other sign is the T sign. And why do you get a T sign? T sign is because here there is optic nerve, and this is the edema in the posterior episcleral space. All right. Ab to ye kabhi nahi bhulega. You will always remember these two signs. So anybody wakes you up in the night and says posterior scleritis, T sign and thickened sclera. Two things that should come into your mind. All right. Is that okay? Can we move ahead? All right. So now identify what is being done. What is this procedure called? Thank you, Shruti. Thank you for the thumbs up. All right. So what is this procedure called? Tono pen? No. Tono pen is something which is more straight. You see the system here, it is curved. IOP? No. Measuring IOP? No. All right. I'll give you a hint here. What we are measuring is we are measuring the thickness of the cornea. Now tell me, what is the procedure being done? Now you will give me your correct answer. What is the procedure being done here? Tell me. Keratometry? No. I've told you it is measuring the thickness. What are we measuring? What is this process called? The process of measuring the thickness is called as pachymetry. Pachymetry. Absolutely. The process of measuring the corneal thickness is called pachymetry. And whenever I talk of pachymetry, it should always strike your mind that the cornea is like an hourglass. The cornea is like an hourglass. It is thinner in the center and thicker in the periphery. Okay, so what is the value that you have to remember? You remember, if you remember one value, it is 1 to 1.2 millimeter in the periphery. Usko half kar do, it is 0.5 to 0.6 millimeter in the center. And the average corneal thickness, in Indian eyes is 535 to 550 microns. These are values, but you have to remember them. ठीक है, अब तो नहीं भूलेगा. So now the process being done here is basically you anesthetize the eye, and you see this is a curved structure. Tonopen is like a pen which is straight. All right, it has a just a slight bend, but it's a very slight bend. All right, so that is done when you're measuring the intraocular pressure. That is the tonopen that is used. But here the process being done is pachymetry, which measures the thickness, and this process is called as pachymetry. And then you should remember the values of the average corneal thickness and then the periphery and the center. So center is half of the periphery, right? So it is thinner in the center and thicker in the periphery. All right, so now you identify this. What is this? The hint is both of these are used for the similar thing. This is easy. At least the B part should come easy to you. This is A and this is B. I know B you will, or keratometry. I'm very happy. The process is, and what is keratometry done for? Keratometry is the method to measure the radius of curvature. So what we see here, this is a manual keratometer. And this being done here is video keratoscopy, which is based on Placido disc. Now, the purpose of showing you this is basically, so this is a Placido disc based keratoscopy. So when we talk of a Placido disc based keratoscopy, what is being done? Is it a type of topography or it is a type of tomography? Tell me, it is a topography or a tomography? Absolutely. So this is what it is doing is, it is the topography study. So I will quickly go through what is the difference. Topography is studying, like it is studying the geographical surface of an area. Where are the mountains? Where are the excavations? What is the surface like? But please remember, when we talk of topography, I will put in here, when we talk of topography, it is like a 3D map of surface, right? And the important thing to remember here is, it takes into consideration the anterior corneal surface only, right? But when I talk of tomography, which is more advanced, like pentacam, Schemfleck based principle based instruments, orb scan, all these study the anterior plus posterior corneal surface. So they take the consideration of the entire cornea, the entire corneal thickness, but topography takes in the consideration only the anterior corneal surface. So which is better? tomography is better, right? So you should be clear with these two things. Topography is just considering the anterior corneal surface, and tomography is taking the anterior as well as the posterior corneal surface, right? So this is a manual keratometer, and this is the video-based Placido disc based keratometer which is done. All right, so now you know what is topography and you know what is tomography. Tomo mein you get pentacam. The examples that you, if you want to write the examples, they are obscan and pentacam. Here the example is Placido disc. Okay, all right, moving on to the next. Who am I? This is easy. This everybody would know. This is A, this is B, and this is C. Now here you have to tell me two things. What is the filter that is used and the sign? Okay, what is A? Come on, quickly. This is easy. What is A? I will write and you will also write. Or the fancy name to this is oil droplet reflex, or the fancy name to this is why is it this? So basically what you get to see is you see a dark reflex. So you see a dark reflex. And which disease do you get this? Okay, so galactosemia is an oil droplet cataract. All right, so that's a cataract which is bilateral, autosomal recessive, which you get to see in galactosemia. But here I have shown you a combination. So that is what I mean to ask you. It's a combination. So if you say A, B, and C, total three things, which disease do you get it? Absolutely. The diagnosis is keratoconus. So what I'm teaching you here is the signs of keratoconus. Okay, so let's quickly see the oil droplet sign or the Charles sign. So it is basically what you get to see here is there's a dark reflex which you see on a dilated pupil, which is corresponding to the base of the cone. Second sign, what is sign B? So now you know it is keratoconus. What is sign B? So what is happening is you're throwing a light here on the temporal side and you get an arrowhead pattern illumination on the nasal side. Which sign is very good? It is Rizzotti sign. Tell me the answer. The two questions that I've asked in option C, which is filter and the sign. Meanwhile, I will write the name of this. This is called as Rizzotti sign. And third, which is the filter that is used here? Tell me. It is the cobalt filter. And what you are seeing, if you see carefully, I will zoom the image for you. What are you seeing here? You see a ring here. If you carefully see, can you see this? Can you see the ring here? Can you see this ring here? So this is, what sign is this? This is the, no, it's not scissoring reflex. This is the Fleischer ring. And why do you get a Fleischer ring? The Fleischer ring is seen because of deposition of which pigment? It is because of the iron which is deposited at the basal epithelium at the base of the cone. Right? And yes, I want to tell you one thing. I have already uploaded the PDF of the entire lecture on the Telegram group. So if somebody wants the PDF, that is without annotations, but that is available on the Telegram group, that is iOrtho, right? So you can download the PDF of this lecture from that group. All right. Okay. So you get that this is the Fleischer ring, which is present at the, because of the iron deposition at the level of the basal epithelium at the base of the cone. Which is next sign? Tell me, which sign is this? This is easy. So this is the Munson sign. When you have the, what you have is a deviation of the lower eyelid when you try to look down. And which sign is this? This is important. This is Volt's Stria. So what stria is nothing but these are these fine lines which you can see here. An important thing to remember that they disappear. When do they disappear? On external pressure. Okay, so they disappear on external pressure. Is that right? Okay, so moving on to the next one. Tell me the anti-glaucoma drug which is responsible for the given image. So before we go ahead, you have to tell me what are you seeing in this image. You have to tell me the name of the finding and then we go on to the anti-glaucoma drug which is responsible for this. I will zoom in the image and now if you can make out. Look here. What is this? Pigmentation? No. This is called as cornea verticillata, also called as vortex keratopathy. So what is this? What is vortex keratopathy? Basically, what you get to see here is there is the deposition which is seen deposits in a whirl-like pattern. You see here carefully. So there's a whirl-like pattern. This is called as vortex keratopathy or cornea verticillata. The important part here is what are the conditions? What are the drugs which are responsible for causing cornea verticillata? So I have a mnemonic here. Yes, I get a lot of that nitazoxanide, imidazole, chloroquine, Faber disease. Very good. Anybody who can give me a mnemonic to remember? Okay, I will give you. Tell me. Anybody meanwhile tell me the mnemonic to remember this is? So the mnemonic is Corpia F. You all say cornea. So just replace it with Corpia. Corpia F. So by C we mean chloroquine or hydroxychloroquine. If you want with the annotations also, I will upload this PDF with annotations on the Telegram group. Then you can get it after this. All right, if you want that. All right. So what is O? O is itovaquinone. R is rho kinase inhibitors. So this is the answer that I was looking for. So the anti-glaucoma drug which causes this are the rho kinase inhibitors. They are nitazoxanide and ripasudil. All right. So P is phenothiazines. I is indomethacin. A is amiodarone. And F is Fabry's disease. So it is Corpia F. The way you remember cornea, it is Corpia F, right? So Pepsi, all right, I take that. And A, B, C, D, E, F, all right. If you can remember that way, that is also one way to remember. All right, so I remember cornea verticillata, which is cornea V as Corpia F. I take that Pepsi and A, B, C, D, E, F. All right, that is to each his own. All right, good. So coming to the next one, tell me the nerve which is affected in this patient quickly. So which nerve is affected in this patient? Before you tell me, come to the nerve, tell me which muscle is affected here. Which muscle is affected here? Let's see. So if you see in the primary position, the eye is in EZO. So the eye is an EZO. It is left eye, which is an EZO. And if you see here, the adduction of this eye is all right. And the movement of the right eye is okay. So here adduction is there of the left eye, EZO. But when you try to abduct the eye, it is problematic. So an eye, left eye, we know which is the problematic eye, left eye. It is presenting with EZO and adduction okay. With abduction loss, what are we dealing with? Which eye are we dealing with? We're dealing with lateral rectus, absolutely. So this is left lateral rectus, and which nerve is involved? Sixth nerve is involved. So we know what are the muscles which are supplied by the superior division of third nerve. So which are the muscles? It is superior rectus and LPS. So it is not lateral rectus. The muscles which are supplied by the inferior division of third nerve is inferior rectus, inferior oblique, and medial rectus. Fourth nerve is supplied superior oblique. Sixth nerve supplies the lateral rectus. So the answer here is the sixth nerve. So we know all the muscles are supplied by the third nerve except LR6, SO4. All right, moving on to the next. Now you have to tell me which is the ulcer, which is bacterial, and which is fungal corneal ulcer. This one is very easy. This you all must know. So what is which one is bacterial and which one is fungal? So coming to A, I will help you. It is a single infiltrate with there is an edema around, well demarcated, with suppuration in the center, with hypopion. So which ulcer is A? Which ulcer is A? Is bacterial ulcer. Whereas if you look at the image B, the image B has, there's an ill-defined ulcer with multiple lesions around, and it's a dry looking. If you see here, there's a poor sheen of the cornea. So hence, this is a fungal corneal ulcer. So let's quickly see what are the points to differentiate. As I just said, when you talk of bacterial ulcer, there is a single infiltrate which has sharp demarcation. There will be suppuration surrounded by edema. And the specific thing about hypopion that you need to know is the hypopion is mobile and it is sterile, because it is caused by not because by the invasion of the bacteria, but because of the toxins. Whereas when we talk of the fungal ulcer, it is a dry looking ulcer with feathery margins, multiple lesions which are called as the satellite lesions. You will have a Wesley ring, which is an immune ring around the ulcer, and hypopion, which is not sterile because the fungus itself invades the AC, and also the hypopion is fixed. So F for fixed, F for fungal. Okay, so quickly revising, when we talk of the pathogens which can invade the intact cornea, so the mnemonic here is no HDL. So that is no, which is Neisseria gonorrhoeae and Neisseria meningitidis. We have H, which is Haemophilus, D, which is Corynebacterium diphtheria, and Listeria. So the most common bacterial organism responsible for causing bacterial ulcer is Staph aureus, and the most common organism responsible in soft contact lens users is Pseudomonas aeruginosa, and the most common in the fungus is the Aspergillus fumigatus, right? Aspergillus fumigatus. Is that okay? Right? So F for fixed, F for fungal corneal ulcer. So this way you will never forget. Let's quickly identify these images. These are easy. These are the lens induced glaucomas. So you have to tell me which type is this. So what you get to see here, there is a pearly white nucleus which is present. The AC is shallow. There is corneal edema. So what is this? Which lens induced glaucoma is this? Which type is this? It is, remember, it is because of the change in the shape of the lens. The lens has become intumescent, hence it has come forward. The pupil, if you see here, the pupil is mid-dilated. There is corneal edema. The AC is shallow. The lens is intumescent. And this is which kind of a lens-induced glaucoma? It is phaco Phacomorphic glaucoma. And this is because of the intumescence of the lens. Right? So the patient will give you a history of a slowly progressive painless diminution of vision, which is super added by a sudden painful diminution of vision. So the initial part is because of the slowly developing cataract, which was painless, which was progressive diminution of vision. But now, since there is a development of glaucoma, so there is a painful diminution of vision, and this is phacomorphic. Very good. Identify the next one. So now what you see is, what is this? Which type is this now? So you see the lens is here. So there is displacement of the lens, the crystalline lens, from its normal position. And when we talk of the displacement from its normal position, which type of lens-induced glaucoma are we talking of? We are talking of phacotopic glaucoma. That is displacement of the position of the lens. Okay. Then we come to this kind of a cataract where there's a hypermature cataract. So what you have is a hyper, you see here carefully, what you have is the convoluted anterior capsule. So convoluted anterior capsule presenting to you with this kind of a pseudo hypopion or a hypopion that you can see. There is edema, there is a dilated pupil. So what kind of a cataract is this? Tell me. Yes, it is phacolytic. Tell me the other fancy name of this kind of a glaucoma. Phacolytic. I always say lytic means degenerative. So you remember, once there is a hypermature cataract, there is a degeneration setting in. It is called as phacolytic glaucoma, or it is also called as which kind of lens? Particle or lens protein? It is lens particle glaucoma. It is called as lens particle glaucoma. Okay, because these are the lens particles. Sorry, it is called as lens protein. I'm so sorry. It is lens protein. It is lens protein glaucoma. Lens particle is when you operate a patient, you do a surgery, you have a trauma, and the lens particles come out and they go and clog the trabecular meshwork. But here I remember it as, when you talk of a hypermature lens, there is change in the lens proteins. So you know there is increase in the number of lens insoluble proteins. So the insoluble proteins increase. These proteins, when degeneration comes out through the microcystic spaces in the interior capsule, they are ingested by the macrophages, and these macrophages go and block the angle, resulting in a secondary open angle glaucoma and a picture like this. So this is called as a lens protein glaucoma, and remember, there is lack of KPs. So if KPs are present, then what will you label it? If the question says the KPs are present with something happening to the lens, then we call it as phacoanaphylactic or phacoantigenic glaucoma. Right? So the phacolytic or lens protein glaucoma will not have KPs. But if KPs are present, then we call it as phacoanaphylactic or phacoantigenic glaucoma. Right? So we are left with few slides, which I will take tomorrow. I will continue with it tomorrow. And meanwhile, I will just end up this class here. I will sign out and we'll meet tomorrow, 3 to 4. We'll discuss further, carry on the discussion from here further. And I say you're not finished yet, because neither you nor I am proud of it yet. Right? So keep working hard, keep learning each day. The D-Day is coming. I said we all are going to write the exam. All I have to mention here is that two things. One, INI-CET comes with a lot of pressure onto you. ये तो नहीं होगा, this is very difficult. But please believe me, there are people like you and me who sit and who crack it. So please trust yourself, trust your knowledge, trust what you know, and go with the full confidence. And secondly, I would say the neuro-ophthalm is a very, very important part, which is which is normally asked in the INI-CET. So anybody who wants to read, because of this time shortage, I will not be discussing the nerves in details. But anybody who wants to learn about third, fourth, and sixth, their roots, their details, you can have. I have a free special class which is already recorded, right? So there's a free class which is present on the Unacademy app by the name of Cranial Nerves and Eye. So here I have discussed the cranial nerve number 2, 3, and 6 and their pathways. So if you want to go and have a look, it will be quick revision to the course of these nerves. So you can see that, you can watch that video. It's a free class which is available there, right? So we see tomorrow, we meet tomorrow. Thank you so much and have a good day.